I would take a slightly different tack than sort of asking, what factors would I consider in choosing a patient for LAIs. I would rather pose the question as to why wouldn't we use an LAI? What are the contraindications? I think it's a treatment that's appropriate for everybody. I think that the first decision that the clinical team has to make is medication indicated? Are we confident in the diagnosis? Have we made the recommendation that antipsychotic medicine is indicated? Once we've done that, then the question becomes, well, how do we ensure that the patient is most likely to get the benefit of the medicine? And so in that sense, it seems to me that we should be using a long-acting formulation whenever we can, so that we feel very confident that the patient will get the benefit of the medicine. Sometimes people are confused that it means that, I'm forcing the patient to take medicine, or I'm taking away the patient's autonomy. I think those are, in my opinion, those arguments don't make sense, because the patient, we're trying to help the patient achieve more autonomy by getting control over his or her illness. We're not trying to control the patient, we're trying to control the illness. So I'd rather ask, why not use a long-acting formulation rather than ask, why should I use it? If a patient had difficulty tolerating a long-acting formulation for some reason, or they haven't responded, we have several choices. There are several different medicines, so it's unlikely that the patient will not be able to find something that they're comfortable with. But we do know that there are a subgroup of patients who are treatment resistant, and those patients should be getting clozapine. Clozapine is not available in a long-acting formulation, and probably won't be, because it has a risk of agranulocytosis. So, if a patient has a contraindication to the particular drug that I'm thinking of, then yes, that might be an obstacle. There are some people who are, very, very frightened by injections. I think they're in the minority. In my experience, even people who are frightened by an injection, even after they've tried it once, they usually, say, oh, gee, that wasn't so bad. So my strategy has often been just to try to get the patient to try it, once or twice, see how they feel. So I don't think there are any really strong contraindications for the use of a long-acting formulation. And we even, I think that patients very early in the course of the illness should be receiving it. So if someone has just been admitted for their first episode, there's no reason why a long-acting formulation can't be recommended when they leave the hospital, even if they've only had one episode. Again, it gets back to, as long as we've made a decision that medicine is indicated, then why not give it in a way that the patient is most likely to benefit from? And it's ironic, because there are many areas in medicine where they don't have long-acting injectable formulations, and I know many of the clinicians treating those patients wish they had long-acting formulations. Many of the patients wish they had long-acting formulations, but we're fortunate we do have some available, so we should take advantage of them. Unfortunately, a lot of clinicians are not great at communicating the potential benefits. I think they may be resistant themselves to the idea. They may be uncomfortable. I've heard clinicians say, I'm afraid I'm going to interfere with the therapeutic alliance if I suggest to my patient that he take a long-acting injection, because I'm saying I don't trust him to take his medicine. I think that's silly. I don't think that this interferes with the therapeutic alliance. I think if anything, it can enhance it if we can spend more time talking about the patient's, problems, rather than talking about whether or not they're taking their medicine. Because when someone's on oral medicine, you end up spending part of each session asking about, did you miss any of the medicine? And if so, why? And et cetera, et cetera. So that can be avoided if someone is taking a long-acting formulation.
I start talking to people about LAI pretty much every time when they first come to me. So if they're in a recent episode, or even if they've been seen in the community for many years, I find that there are people who aren't even aware that LAIs are a choice. And why shouldn't they have that choice? So I often talk about them. I bring them up in the context of recovery goals. So instead of saying, I have this injection, which is never going to work, I say, it doesn't seem like you're doing as well as you'd like to be doing. You want to take better care of your animals. I have a medicine that might help with that. Are you interested in hearing more? And they always say yes. And then I say, and you only have to take this medicine every month or every 2 months or every 3 months. Are you interested in hearing more? Now they're really interested in hearing more. And then I say, by the way, you would come into the clinic and we would give you an injection. And some people will say, no, I don't like shots. You know what? I don't like shots either. I don't know a lot of people that like shots. I don't think I've ever met one person that likes shots. But the issue is that the amount of time that it takes to get any injection, like a flu shot, the pain lasts that long and the protection lasts a very long time. And so it's the same with schizophrenia. The pain of the injection lasts this long, but what's the pain of a relapse? How much trouble is that gonna cause you? And you have to really weigh the pros and cons before you just say no. And usually I point out to people that most of the studies show that on a scale from 0 to 100, the pain of an injection is below 10. You think you can handle that? Usually they can. I say, maybe you want to give it a try. Try it for a few months. Try it for, half a year. See what you think. And we can talk about it again. And if they say no, I don't stop there. I bring it up again, and I bring it up again, and I bring it up again, because I think it's really a valuable tool to set the framework for somebody's recovery. And if you tie any medication to what the person wants, I think it's easier for them to be very accepting. I haven't found much problem trying to get people to accept long-acting injection. The protocol for initiating long-acting injections, I think, is most people just follow the guidelines that are presented by the APA or other organizations. But I do find that there are some prescribers that use a lot of long-acting and some that use very little. And we've done a lot to try to get our prescribers in our organization to use long-acting injections. So in the clinics that I'm affiliated with, we use a checklist to identify people who aren't doing so well. Maybe they've been in an ER or a hospital, or they don't have good control of their symptoms, or they tell you, oh, I've missed a few doses here and there. Chances are they've missed more than they remember. Have you tried multiple antipsychotics with them? Are they on more than one at once? Any of those things are red flags for you. Have you offered a long-acting injection? So it's a simple checklist with 5 questions. If you answered yes to any of them, did you offer a long-acting injection? And what that does is it kind of keeps LAI in their face and reminds them to make that offer. And what we found is that using that checklist actually does improve increase the use of long-acting injection. We also have used a patient-facing video. So it's a video about shared decision-making. What's your role in shared decision-making as a patient? You need to tell the doctor certain things. You need to ask questions, and you need to make a choice. And how do you make a choice, for example, between tablets and long-acting injection? So they see this video with all the pros and cons, and then it says, what would you like to do? And if we show that video, many of the individuals will go into their provider and say, hey, what about this long-acting stuff? Is this a good idea for me? Let's talk about it. And they'll start the conversation. So if you hit it at both of those angles, you're much more likely to be able to increase long-acting injection use.